Hi, I'm Ralph Preston, and every Tuesday we have these Stroke Buddies Recovery and Science Zoom meetings. And the point of them is to try and bring you some useful information for your recovery that's based on science. I'm a big believer in science. I think the more you know about science, the more focused approach you can take to your recovery. And I think a focused approach is better than a non-focused approach. So today we've got uh, uh, from all the way from Australia, we've got David Straney. David's a neuro PT. He knows about more than gait and the gait transition from wheelchair to walking to running, but that's what we're going to focus on today. So David, it's all yours. And thank you for taking time out of your schedule. And it's morning for him and afternoon for us. So it's a little crazy, but here we are. And so welcome everybody and welcome David. Thank you.
Thanks, Ralph. I appreciate that. Let me just share my screen before anything. There we go. Hopefully. Great. I think that's it there. Well, yeah, thank you, Ralph, for having me, and thank you everybody for jumping in on the call. We've got a good turnout today. Before we get started, as Ralph said, my name's David. I'm a neurophysio. During this presentation, I just want everyone to be clear with a bit of disclaimers that I can't give any personalized sort of medical advice or sort of anything specific in that sense. But hopefully you get something out of today, as well as just remembering, although this is about going from sitting or going from the wheelchair to running, everybody's stroke and everyone's recovery is different depending on where your stroke is, the size of your stroke, and so many other factors. So although some people may not be able to get to that stage of running, even with the perfect rehab program or whatever it may be, it's still, there's so many things you'll be able to take from this to improve where you are now in your current rehab recovery program to get you 1% better every single day. And that's the main goal. Okay. But yeah, so today we're talking about going from sitting to running after stroke. But before that, a little bit more about me. Who am I? So my name's David Straney. I'm the owner and principal physiotherapist of Neuro, which is a mobile and a telehealth physiotherapy service. So I do mobile or home visits in the Sydney area in Australia, and I do telehealth stuff all over the globe. I got my Bachelor of Health Sciences with a major in movement science at the University of Sydney before completing my Masters of Physiotherapy at the University of Sydney as well. I've had a pretty wide variety of work settings and experience. So on the neuro side of things, I've worked in private neuro clinics, so non-government organizations early on in my career, before moving on to some mobile physio clinics, still in the private system. Before I moved over to London for a couple years, and I was doing locum work over there. So I worked in the acute and hyperacute stroke wards, which I don't know in the US if you guys have hyperacute stroke wards. What that simply is if you have a suspected stroke, you come into the hospital and there's a specific ward for people with suspected strokes, where they'll be seen within the first sort of hour by physios, OTs. They'll get their scans triaged a lot faster, so we can get treatment done a bit quicker. So work there, acute stroke wards for that inpatient rehab, as well as some community work within their government system too. What that's all allowed me to do is see people going from their initial strokes to the day one, all the way up to when they're back home for that long-term plan. So it's given me a nice perspective on what people might be getting in hospital, what they might be getting at home, or what they might not be getting at home as well. And then after that, I came back to Australia and started Neuro. My mission overall is in the next year, I do want to help 100 people globally, specifically for strokes, ideally, but I'll help anyone I want to take their rehab from only in their rehab facility to back home to increase their function independence. The reason why this is when I'm in hospital, working in a hospital, I see people making great progress. And as you know, that's generally where we make the most progress within that first sort of 6, 12, 18 months. But when we get home, people stagnate, they plateau. but they don't really need to. And we'll touch on a few points on why that might be happening, apart from changes in sort of progression due to neuroplasticity and brain development. But overall, we should be able to make progress across our whole lifespan. And I want to make sure people have the opportunity to do that. A bit of housekeeping. Ralph already touched on a few of this stuff. Ideally, I want people to be interactive. I can't see the chat. So Ralph, if people are asking questions, I can see you in my screen, so that's helpful. Just let me know. Otherwise, for at the end of the presentation, I'll have a question time. So put in the questions for the end, or if it's appropriate during, I'm happy to answer things as we go. But there are no stupid questions. I'm sure lots of people have been on these calls before, but there may be people that haven't been. I'm not too sure, Ralph. So even if you feel like it's a normal basic question, ask it, and I'll be happy to answer.
I'll try and keep up the chat for you.
Thank you, Ralph. I appreciate that. If I'm looking up, it's because I have a second screen. Just quickly before I get into everything. So how I approach my rehab, so you guys get a bit more of an understanding on me as a PT. I've got this little triangle model, which I base my 12-week program, which I've recently developed, focusing on three main points that I find stroke survivors have issues with, which is low independence, falling, and plateaued recovery. And improving those three aspects can improve their quality of life. And when we're talking about returning sort of function from sitting up to running, all of these aspects come into play. And you can see that it isn't a simple thing where, oh, I just need to fix one part of my rehab or one part of my life. It is a complex sort of system. So it is understandable why people have difficulty getting to their end goal. But if we can target these different aspects in an effective way, then I've found through my previous experience that people can still make really good progress, even if they're years down the line post-stroke. So with going from sitting, going from the wheelchair to running, we're going to be focusing more so on the mistakes that people do and how to change those. So the first mistake is skipping steps. Much like when we're kids, we can't say you can't crawl and run. Same thing with rehab. You can't skip steps. When you skip steps, there's holes in your body in the sense that you might have undeveloped motor patterns, you might have underdeveloped muscles of weakness, and then you might get past one stage, so you might be able to go from sitting to walking, but if we haven't done all the steps beforehand, when we try to get to running, it won't be either efficient, effective, or it might not be possible at all due to some of the deficits you still have. So making sure you don't skip steps, and we'll go through all that again. Second, not enough good reps, not enough good repetitions. So everyone might be aware, and hopefully is aware, that neuroplasticity is the ability for our brain and our body to make new and strong connections. Okay, and the main principle with that is repetitions. Okay, getting enough repetitions, get enough practice so your body can rewire. Okay, but the problem I find is people aren't getting enough of these good repetitions. And there's three sort of main points that I like to focus on: intensity, volume, and frequency. And this is within sort of your exercise sessions or your rehab sessions. So what intensity is how hard are you exercising? Are you being a bit laissez-faire? Are you being a bit going through the motions when you're just doing your exercise? Or are you putting your full attention, full effort in, working as hard as you can? So that's intensity. Volume is the amount of sets and repetitions you're doing within an exercise. So for example, if you're doing a reaching and grasp exercise, are you just doing one or two, then resting? Or are you doing 15 or 20 in a row, resting for 2 to 5 minutes, then doing 15 and 20 in a row again? So that's your volume there. And then frequency. How often are you exercising? How many days a week? How many times a day? And how long each of your sessions? So all of these come into play. And I find most people, especially when we go home, they're not getting enough good repetitions. Not training for running. So people want to run, but it's important to remember, if you want to run, we've got to train to run. It won't just happen overnight. You won't just say, oh, tomorrow I might run, then it'll just work. Unfortunately, with impairments that come from a stroke, there are a lot of deficits we need to work on and build up technique that might be required before we actually try to do the full task of running. We might need to break it up and do some part practice and specific exercises to build up. So when people avoid the actual activity, there's a big problem. And then the last mistake is missing tendon time. So our tendons, specifically the Achilles tendon for running, is really important. Okay, if you don't have a strong, stiff Achilles tendon, which we'll touch on later, you won't be able to really run. You might be able to jump from one foot to the next, but what we consider running can't happen, which Ralph actually talked on earlier. I know he's mentioned that some of his old PT friends believe that without a strong ankle, you can't run. And this is under that same category where the ankle, the Achilles tendon needs to be addressed properly, which is a bit different than when we're addressing other muscles or parts of our body. So to start off, skipping steps. When I think about rehab and when I think about people progressing in their function, I use this generalized sort of mobility scale where being in bed is the sort of the lowest level of mobility we can have, where we're bed bound, we can't get out of bed alone, and the most we can probably do in bed is our bed mobility. Okay, all the way to the end, which is running, jumping, sort of peak of human performance. Okay, and then we've got steps in between, right? So from being able to do your bed mobility, then to be able to transfer out of bed, to then be able to walk on flat ground, to then being able to do stairs or more challenging sort of walking terrains, to then finally running. So without skipping steps, we need to make sure we're ticking the boxes on each of these sort of movements or skills so that we develop the proper strength, the proper technique, which carries on to each next skill. So we're going to go through all of these each and talk about what we need to have developed and what might be your next step. Before that, there are impairments, as you may know, that's going to affect us from getting to the next step. And that's the reason why I said at the start, not everybody will be able to go back to running. It's just unfortunately impossible, depending on what the deficits are. So if you've got deficits in balance and you can't stand, okay, then we can't even think about going to walk, okay? Same thing if you've got deficits in balance and you can't sit without falling on your own, then we need to still think about that before we start thinking about even standing, okay? So balance is key. Spasticity. Now, this is something I get a lot of questions from people. Oh, actually, I do have the chat, Ralph. So what I'd like to ask everybody is, what do you think spasticity is? And I'm going to come back to that. So in the chat box, if you can, just write down what you think spasticity might be. Contracture is the next one. So when we're thinking about after a stroke, we can get something called increased tone. And we can have low tone or high tone, hypo or hypertonia. So hypotonia is essentially when our muscles lose their stiffness, their tightness, and can get nice and floppy. Think an arm that just drops, and it's almost like that wacky inflatable arm man that's in car stores. So that's low tone, and high tone is when it is very, very stiff. Okay, you might be able to move it, but it's got a lot of resistance when you're moving it. Contraction is the extreme of the high tone, where the body is now stuck in a position, okay? And then that, even when you try to push it, it can't move. So it's contracted and requires sort of more surgical or medical intervention. We've got a few different answers here about spasticity, which is great. So tightness in limbs, muscle stiffness, velocity dependent, and neither, that's the one, and no signal from the brain to not do something. So Linda and Dan, you guys were on the right track where there is the tightness and the stiffness in the muscle, but with spasticity, we need to sort of make that a little bit different because it is velocity dependent, so speed dependent. where we'll find with spasticities, there's different categories, okay? But what will happen is if I move my arm slowly, okay, it might move nice and smooth. But then if I try to move my arm quickly, it might do a number of things. It might catch and stop and then slowly straighten out, or it might go through something what we call clonus, which is really common where it's you go fast and then it will start shaking. Okay. And that's the difference between spasticity and just tone, where it's dependent on the velocity, okay, on the speed in which you're moving. And with that, as we're thinking about doing higher level activities, like walking, like running, when we have spasticity, we are going through these quicker movements. So it comes into play a little bit more. Um, and yeah, Daniel, that's what you experience. And it's really, really common. But there are treatments we'll touch on a bit later. And people can actually use some of these, a bit of spasticity, a bit of tone to help with their movement. Muscle strength is the next thing. Pretty obvious one. If you're too weak to hold your body up, perform a movement, stand, step forward, then that's going to limit you in being able to do an activity. Motor skill level, which is that's your ability to have coordination is probably the next easy word I would compare that to. So being able to do what you think. So I want to bring my hand and grab my coffee cup and have a drink. Poor motor control means I might miss it. I might not be able to reach it. There's a difference in sort of connection there. Other areas, so our vestibular system, so relating to our balance as well, but that can make us dizzy and whatnot. Vision, sensory disturbances, as well as our perceptual-spatial disturbance. So knowing what's around us, all of these things can come into play that will limit us in our ability to move across that, where's that mobility scale? Across that mobility scale. So starting at the start, where everybody starts when we're born, bed mobility. So the first thing that kids are taught to do is that tummy time. Get them on their stomach, okay? So they can build up strength in their back and their head. For us, getting back to rolling in bed is really important. Okay, so being able to roll from your back to your side to your other side. How you progress in that might be with assistance at first. It might be holding onto a rail on the side of the bed before you start progressing to doing that independently, using your own muscles. From after rolling or during rolling at the same time, with all of these, it's important to note you might not do any of these in order. You might be doing multiple things at once, and you might be actually missing something from the bed mobility, but still working on something in your transfers. Okay, everybody's different, so important to remember that. Apart from rolling, we've got bridging in bed. Bridging is such an important activity. If I'm on the far left side of my bed and I want to get into the middle, using the bridge is a great way to get your hips out of the way, push them across so you can readjust. In addition to that, getting dressed early on, being able to get your pants on, bridging is so important if you want to be able to do that independently. As well as it's a great way to build up real quality strength, okay, in your glutes, in your thigh muscles, in your core. It's such a great exercise and can be progressed really hard. I do bridges. I give all my healthy population patients and even athletes bridges to do. So it's a great exercise. And then going from lying to sitting. Okay, this is sort of the hardest thing within your bed mobility. Be able to go from laying in bed to sitting on the edge of your bed. And then from sitting on the edge of the bed, being able to do that independently. So you might start by getting help to sit up onto the edge of the bed, okay? Or you might use a grab rail or something similar to help you get onto the edge of the bed. When you're sitting, you might need assistance of one or even sometimes two people to maintain your sitting balance. But as you get better and as you keep practicing, the goal is to be able to maintain independent sitting balance because we need that. And we need the strength that comes with that in the core, in the hips, okay, before we move to standing and transfers. But before we think about standing by ourselves, after bed mobility, we move to transfers. So there's a few different ways of transfers. And what transferring really means is just moving from one place to another. Generally, maybe a chair to your bed to your chair, or your wheelchair or something similar, a commode toilet. So before we're able, or some people might be able straight away, but for the most impaired individuals, the hoist is going to be something you're really familiar with. And that's the number one thing we'll start with to transfer people that don't have any physical ability to transfer. So that's using a hoist. So it's going to lift you up, take you across, and they'll put you down. With this, you're not going to be able to develop anything from this activity, okay? Apart from maybe a little bit of fear, because I know some people can find that pretty scary. This is actually my wife in the picture. She did not like me doing this with her, so she can appreciate that fear as well. But after the hoist, moving to something that involves you a little bit more, which is different pieces of transfer equipment. This is the Sarah Steady here, which some people may have used. You've got other ones like the Return, but something that allows you to stand up. Okay, you do have also standing hoists, which forces you to stand up. But a Sarah Steady is something that you'll stand up on your own. You're secured in with your hands and your shins supported, and then you can sit back down to some paddles to allow you to move around with the help of assistance. So you're getting some involvement, you're getting some leg strength, some arm strength development, okay? But you're still unable, once you get to the Sarah Steady, to move from there. When you're getting a bit more strength and a bit more independence, then you might move to something like a slide board transfer. So that's just a board which you put underneath your bottom, and then you can just crawl across on your bottom from your chair to your bed to your chair. Really good strength, or really good force strength rather, and is significantly harder than a Sarah Steady, than a standing transfer piece of equipment. You can get help, but requires a lot more balance, a lot more coordination, but still isn't anything relating to standing and walking. Okay. Once we are happy with all this equipment-based transfers, and we want to move to the next stage, we'll generally start with something like a pivot transfer. Okay. So these transfers are when your chair or your bed is right next to your chair or your bed. Okay. So you're moving probably a foot across. So a pivot transfer is when you do a mini stand. So you won't get up all the way, and then you'll just swing your hips across. Okay. So you can clear the empty space and get yourself to your seat. You're still not standing up all the way. You're still not taking any steps. Okay. But you're using your legs. You're getting some clearance off the floor, which you weren't with the slide board, and you're progressing a little bit across to that next stage, which is the step round transfer. Okay, so when you do a step round transfer, this would be probably for the mobile, the walkers that we have in the call. This would be your earliest time where you're actually taking steps, okay, in a functional way. So you'll stand up, and then you'll take one or maybe two steps to get your body in position to sit down. This generally will start with assistance before you can do it safely alone. Once we can do that confidently and safely, then we'll start doing more normal transfers like we'll do prior to the stroke, but with mobility aids. It's important to remember at this point that at this point you should already be standing. You might be practicing walking, okay? But your mobility transfer, mobility aided transfer rather, might be with a different piece of equipment. So this person here has some Canadian crutches, some elbow crutches, which I don't find happens too much in the stroke population. Generally, you'll be using another piece of equipment, which we'll touch on. But after you can do a transfer with just an aid instead of somebody being with you, then you'll start doing it alone. Once we're pretty confident with our transfers, especially once we get to a step round transfer, then we can start thinking about progressing to walking. What we need first before we think about walking is standing balance. If you can't stand without falling, okay, and this is standing on two legs, okay, we don't want to think about walking, because what walking is stepping and rebalancing every single time. So we want to make sure you're nice and strong and stable through the hips, through the trunk, okay, through the ankles and the knees in just standing before we get to walking. With standing balance, something to remember is you don't need to be the best balancer on your feet. You don't need to be able to balance on one foot to be able to start walking, okay? But there is a standard of balance that we want to achieve, It's a little bit different per person, but generally being able to stand independently, so that's no one holding on to you, for at least I like a good 30-second mark to even start considering walking. But you can probably start walking a bit early if you have a lot more support. So people are there to stop you from that risk of falling. Once we have our standing balance, then we can start trying to walk. So walking first will happen, as you guys know, probably with an aid or with assistance. With the assistance is basically just subbing out for an aid. There's so many different types of aids that people might be using, and you guys might be using these today. So we've got in here, we've got a picture of a 3-point stick, walking stick. You can also get a 4-point, you can get a single point. Okay. Some people might, if they've got decent upper limb strength, they might also use a 4-wheel walker or a pickup frame or something similar. So what that's going to be assisting with is your balance a little bit more, as your weak, your affected side can't hold your weight as much. Or you just want to make sure you've got a little bit of safety in there. Once you have developed a bit of strength, a bit of skill with your walking with an aid, and you've built up that confidence, you've built up the correct form, technique of walking, then we want to start moving to walking without an aid, but generally starting that assistance. It might be somebody holding your hand again, or it might be somebody nice and close. Once you get confident with that, and you've again ticked the boxes that your form is correct. We haven't got anything that's and see you later, Mark. That's going to cause you to fall. We don't need perfect walking, okay, because that will develop and that will come with time. But a safe walk, then we'll start walking without aid, sorry, or with aid independently or without aid. Okay, with walking, as we know, it's not as easy as just walking. Once we can walk in straight lines, okay, in clear spaces. So if you think back to maybe your hospital ward, your rehab ward, just walking down the halls, then we want to start making things more difficult. Because unfortunately, in the real world, when we're walking, it's not that simple. We might be changing directions, especially in our houses. Okay, changing directions. There might be obstacles in the way that we need to avoid and navigate. Crowded areas can be quite difficult because of the extra stimulus, the chance that somebody might bump into you, and uneven surfaces. So being able to challenge yourself with walking in all these different environments with different sort of complications that are going on is really important to develop that skill to a higher level. Trent said, I have no idea how much my arms were involved with walking. Yes, really, really involved. And even more so when we get to running. And we'll talk about that a little bit later. And after walking to get to running, I've got in this slide a high level progression. Okay. So essentially, it's what I'd refer to as the hierarchy of difficulty in walking. So at the top here, we have walking, and that's walking on flat ground. Now, before we need to think about running, we've got this checklist that I like to go through to make sure we can handle harder tasks, which also develop the skills to allow us to run. So from walking on a flat ground, the next most difficult thing is walking up slope, so up a hill. It's basically the same technique as walking, except now we need to lift our leg a little bit more. Our center of gravity, our center of mass changes a little bit, okay? And then we have to carry ourselves up a slope, so it requires a little bit more strength as well. Walking down slopes is even harder than that because momentum will be carrying you forward, so you need to stop yourself from almost rolling forward, okay? Controlling your body so it doesn't give way as you're stepping down is a little bit harder than when you're walking up. Which is quite similar to then ascending, also going up and descending or going downstairs. So walking upstairs is like walking up a slope, except now you'll generally be taking a larger step. And then from there, you won't be able to dictate how large your step needs to be. When you're walking up a slope, you can take really small steps, okay? Depending on what your ability is. With stairs, if the stair is, I don't know how my inches to centimeters is difficult, so apologies. But if it's a 5-inch step, that's a lot different than your normal walking up slopes. Once you can do that, so ascending and descending stairs and walking downstairs, again, because you have to control your body a lot more to stop yourself from falling. we want to think about how you're walking up and down stairs as well. So being able to walk upstairs, so 2 feet on each step, which happens really commonly at the first point when we're rehabbing. So taking, if your strong leg is your left leg, you'll go left leg up, then you bring your right leg. Left leg, right leg. From there, you want to be able to progress to what we call reciprocal steps. So only 1 foot on each step. So like what most people will do before their stroke. So being able to develop that is that next stage in addressing stairs. From stairs, once you can do that, the next most difficult thing is walking on our toes. You might wonder, why do I need to care about walking on my toes? The answer actually probably is it might not be important. And this is something I forgot to touch on at the start. Depending on your goals, some people don't want to run anymore. So it's not exactly necessary. So really, for most people that don't care about running or getting back to running, you can stop at the stairs point because all these skills following are related to improving your ability to get back to running. Okay, and that's what the walking on toes is related to. So if your goal is relating to running, then you can keep going down the line. So walking on toes, so building up that strength in our ankle, in our Achilles tendon, okay, which is the nice strong tendon behind our ankle, okay, by walking on our toes, building up strength there, because when we're running, if you look at the Olympics, and we'll touch on this later, you don't see anybody running on their heels in the Olympics, and there's reasons for that. It's more effective, it's more efficient, it allows us to utilize our body properly. So building up the base level strength, walking on our toes is a necessary skill to learn before we're thinking about doing anything dynamic. And by dynamic, I mean being able to move in quicker ways and more explosive ways. I've got a question over here. So is the goal to walk the stairs up and down without holding on? Can you describe bounding a bit more? We'll get to bounding right after I answer that first question,
Yeah, I
Stephanie.
hit the button too quick. Sorry.
No, you're fine. You're fine. It's a great question. So you're on the right track there. But with the stairs, yes. So we want to be able to walk up and down the stairs independently without rail. If your goal is to be able to run, okay? So if you can't walk down the stairs and up the stairs without holding on, then there's going to be a limitation somewhere. It's going to be generally probably your balance or your strength in the leg, potentially coordination, motor control as well. So if you're unable to do that on the stairs, if you try to then run with that same ability, okay, you won't have a high level of balance or the high enough level for balance for running. You're likely your legs will give way because there's a lot of force going through your legs when you're trying to run, and you're likely to fall. So yes, being able
I,
to walk up and down stairs without your hands is important. Yeah.
I find fear is a bigger hindrance to me than anything, frankly.
Oh yeah. Everything on this, but if I go back, almost every single step, probably one of the biggest things that's going to stop you, especially at first, is fear. And that's normal. And I think it's important to recognize that it is scary and it's scary for a reason. And there are risks associated with it. But knowing that you've done the steps before and you're ready to take the next step, I think is important. And then sometimes it's doing the activity and unfortunately making mistakes is also necessary to get over that fear. Because sometimes mistakes won't lead to bad outcomes like falls. Stephanie also asked, is it prudent to learn to run just for emergency? No, running can be great for an emergency. There is rather great research to show, and I've got the stats somewhere around here. By being able to run, it increases your return to work or the likelihood for you to return to work. I think it's 3 times, maybe 4, or maybe even 5 times. It's within 3 to 5 times. If you're able to run, you're more likely to be able to return to work. So it's a nice predictive factor for general function as well as general health. Another good reason to be able to, what happened there? Sorry, guys. To be able to run is just to give you options. Really, I think the main thing with rehab and improving people's function is to, yes, give you more options, more independence, more choice. Because at the end of the day, I think choice in what we want to be able to do can create the best quality of life. But moving on after walking on our toes, building up that strength in our toes without doing anything dynamic, we want to go to bounding. Now, what is bounding? Bounding is essentially, it's actually very similar to running. And I've got that bolded there. So bound is in bold because being able to bound is the most important step or the most important skill to be able to do running effectively. Okay, because what bounding is, it's going from one leg to the next, okay, in almost a jump type of fashion. Okay, so where you're clearing the ground. So I'm jumping from one leg to the next, okay, and then continuing on. So we can go, generally we'll do bounds for maybe 5 to 10 different reps, which is similar to running. It's generally a bit more explosive than running, but it is the most similar movement to running, even more compared to walking. And it can definitely be scary, Trent. I agree. Of course, now we're going from the safe, the ground where we're grounded. Once we start bounding, that's the first time in which we're actually sort of in the air with nothing on the ground. So it takes a high level of skill, high level of strength, and a high level of courage as well to achieve. But naturally, once you can bound, you're basically already running, and then you just need to keep bounding and generally bound a little bit quieter is probably the word I'd use to start to run. So when you can run, you've got different types of running, and then that things to think about as well. So sprinting is slightly different to running quite slow. So developing those different skills. But after running, there's actually some of these other skills, as well as there's lots of other drills too. But hopping, okay, which is like bounding, except you're going from one leg to the other leg, okay? And then as well as skipping, which is a higher level coordination skill that requires both the same movements of bounding and hopping, but also you do a bit of a double jump on one leg. Nita Rose, can trampoline rebounding be a good practice towards bouncing or bounding? Yes, 100%. I've actually, you'll see I've got a trampoline at the end. Trampolines are great, and we'll touch on that a little bit more in depth down track. So my next question for everyone is, where are you on this scale? So if you can, in the chat, just write in where are you in the scale if we go back. So are you currently working on your bed mobility? What are you finding difficult? Is it your bridging, you're lying to sitting, or are you working on transfers where right now you're doing a step round transfer, or you're just doing a pivot transfer? Or are you currently walking, okay, with an aid, or walking with an aid and assistance? Or are you practicing walking in crowded areas or obstacles? Or are you in these high level progressions where we're working on something like stairs, walking up slopes or hills? Or are you even running at this point? And if so, depending where you're at. So Ian and Stephanie both are at stairs. So your next step then will be, and naturally it's dependent on a lot of other aspects of your current training, might be learning and walking on your toes. We've got David here walking with a quad and a single point stick. Some steps with a railing, really good. So then you'd be working at, then David, moving from that quad stick to maybe just the single point stick, while still working some of those later progressions. Linda, mobility aid and assistance, great. So you want to be working on building up some more independence there. Walking with a cane and AFO with stairs, really good. So working on building up that independence with your walking while still building up your stairs. I don't actually touch on too much today, everyone, on sort of AFOs and sort of assistive technology, bracing and whatnot. I touch on it a little bit, but that's something that is to be considered as well. Ralph's running short distances, not coordinated. So lots of, for you, Ralph, that would be moving into the more highly specific drills for you, similar to actually what normal sort of runners would do, if that's something you care about. Rhonda's walking with a quad cane and working on uneven surfaces, really good. Still deals with a great deal of spasticity and sensory pain, suffered a thalamic stroke, and then walking up and down stairs for Carly. All right. And I'm getting a bit of sun outside, so this is nice. All right, so that's great. So now you guys just need to take this, think about what's your next step. If you're already doing it, great, keep going. But if you find you might be taking skipping steps and you're working on something that might be a bit out of reach at the moment, okay, you want to make sure that you are taking those steps before, so you set yourself up for success, okay? And Linda, yes, we can talk about that at the end. The next mistake that we're talking about is not enough good reps. So that was the intensity, that was the volume, and the frequency, okay? It's a tough question because the question, I guess, that we're trying to answer is, what is a good amount of reps? And how do we know? Who knows? Who do we ask? And am I doing enough? Where I look into is the research, okay? And specifically what we have in Australia, which is a really, really good research, which you guys can also get. But I'd imagine they've got something similar over in the US for our US listeners. Definitely they do in the UK. But this is the Stroke Foundation, and they give out, or they come out with clinical guidelines for stroke management. Okay, so this is a list of 8 different sort of chapters where they touch on different sort of points in the stroke journey, and what the evidence is currently saying is the best way to approach it. Okay, what's the best way when somebody comes into hospital to manage them? What do we need to do for them? Okay, what's the best assessments and how do we get the most accurate diagnoses? Today we'll be looking at some of the data from chapter 5, which is related to rehabilitation. This chapter is so good, and it's really in depth. There's over 200, I think there's maybe 230 plus pages just in the rehabilitation side of things. So this is where I'm going off today, and I use to guide my therapy based off the best evidence without needing to go across the whole world to look at a million different sources. It's important to recognize with this, when we're home, there's a big difference from what we're doing in home to what we're doing in hospital or in inpatient rehab. When we're in hospital, we're generally getting, and there are some differences here, 5 days a week of therapy, and that can happen 1 to 2 times per day, okay? Plus, then you might be having group classes, you might be doing stuff on your own. When we get home, that might be different. So again, I'd like everybody to tell me how often are you doing exercise at home? And by exercise, I mean more structured exercise where you're sitting down, you're like, okay, I'm going to be doing this. I've got these many repetitions I want to get through, or I'm going to spend this much time doing exercise. So I'm going to give everyone a moment. I'm going to have a sip of coffee. And how many times a day if you're doing it every day? Okay. So Nita Rose, every day, 4 to 6. I'm not sure if that's 4 to 6 hours or like 4 to 6 p.m., but either way, still really good. Ralph did 10 to 12 hours a day for 15 months. And it shows, Ralph, I must say. Musong is 4 times a week, 25 miles a week on a bike. David does most days, but needs more structure. Rick, every day, 1 to 2 times per day. Thank you, Anita. So that's 4 to 6 hours for Anita. Really good. Trent, a couple hours a day. Jerry, 3 to 4 a day. Rhonda, living independently and alone, so she has little time to do structured exercise. Stephanie, 2 times a day, 4 days a week. Rita, 2 hours a day. So a lot of variation there. What I see a lot is someone similar to Rhonda, where they might live alone or they have little support. so they have little time to do exercise. And generally, even for the people that have support, what I find when I go into people's houses or see them over telehealth is they're only doing a very low amount, maybe once a day or once every second day at the most. But what is enough? Is doing 3 to 4 hours a day enough? Is the goal to get what Ralph is in getting 10 to 12 hours? Is that ideal? This is what sort of the stroke guidelines are recommending at the moment. So for stroke survivors, rehabilitation should be structured to provide as much therapy, and that's OT and PT, as possible. Okay, so they actually don't give us a maximal. Okay, because as you'll find, most people can probably do a little bit more. And what they also recommend as a weak recommendation. So strong means there's lots of evidence for it. Weak is low evidence. But what they say is a minimum of 3 hours 3 hours a day of scheduled therapy. So that's OT and PT. Okay, so that's structured, that's thoughtful therapy. Ensuring 2 hours of it is active task practice. And if people don't know what they mean by active task practice, that means basically practicing the task you want to get good at. So if I want to get better at grabbing and picking up this coffee cup and bring it to my mouth to drink, lovely. I want to practice that task. Okay, if I want to get better at walking or standing, I want to practice walking or standing. A problem a lot of people get into is exercising for the sake of exercising, which is great for our lungs, for our heart, for our brain, but it's not great in developing skills. So we need to make sure we're spending a very solid amount of time. So as they say, at least 2 hours a day is what they recommend, of doing specific practice of the task you want to get better at. Okay. They note in this as well that group exercise classes can be a great way to increase therapy time, as well as doing it alone or with assistance or supervision is important. Unfortunately, they don't give us anything too concrete, which I know for some people can be frustrating, as there is uncertainty as to what the optimal amount of therapy time is. So, and everybody might be different. Okay, so it is finding where you can get to. Okay, the good sign from this as well is they do mention that there is no harm reported in the research they looked at to increase scheduled therapy time. So by people increasing their scheduled therapy, they didn't actually injure themselves, hurt themselves. Something we need to consider is fatigue. As we know, a lot of stroke survivors suffer fatigue. So for most people, that's going to be your limiting factor. Okay, so what we don't want is to push our fatigue too much that the next day we can't do any exercise. Okay, but what we're probably less worried about with our stroke rehab is overdoing our muscles and tearing our muscle, injuring our muscle, like we may have when we were younger. I'm not sure if anybody played many sports or went to the gym prior to their stroke, but you definitely can overtrain. Okay, I can't go out today and just decide to run a marathon. If I do, I'm going to be very injured. I'm going to tear a muscle probably. I'm going to damage some tendons. So I can do too much exercise at the moment, but when we're thinking about stroke rehab and therapy, thankfully, that's not something we're probably considering as much. So what will you do? That's what I pose to you. If you feel like I've only been doing 2 hours, maybe you can do 2 hours and 15 minutes. See how that goes. Every little bit is more repetitions in the bank. Okay. So as we're adding more repetitions, okay, we're increasing our chance of neuroplasticity. Okay. And we're helping the brain through neuroplasticity to develop new connections. So if you have the scope to, so the fatigue levels are manageable at the moment. Okay. You have the time throughout the day. Okay. And you have the ability, and even if it's something very simple, try to increase your activity throughout your day, your scheduled therapy time, and I'm sure you'll see the benefits. It may not be in a week, it may not be in a month, but as you accumulate that over time, over months, okay, and over years, as it's a long time journey, you'll definitely reap the benefits. The next mistake is not training for running. Okay, as we talked about before, you want to be specific with your training. But with running in particular, it's important to note that running is different than any other activity you've done before, although it is similar to walking. But what is the difference actually between walking and running? Another question for everyone. Can you put down in the chat box, what do you think is the difference between running and walking? What makes running running? Why isn't it just still called walking? I'll give you a second for that. All right, so I'll read them as they come through. Carly, we've got speed. Okay. Stephanie, more bounce, speed. Ralph, both feet off the ground at the same time. Lovely, lifting your legs completely off the ground from Trent at the same time. Great. I think we're on the right track with a lot of these. Running involves larger stride. Love it, Rick. Awesome. Pretty much everybody is correct. The main difference that we look at is with our feet. And what I mean with our feet is what we call flight time. Okay. So when we're walking, if we look on the left of our screen, you see this gentleman about to take a step with his right foot. As he takes a step with his right foot's going to be coming off the ground and his left foot's still going to be on the ground. Okay. And they're just going to continue. So there's always one foot on the ground at all time. Whereas with running, we have this period in which both feet are off the ground, which we call flight time. So when we're bouncing, yeah, we have both feet off the ground at the same time. And that's the main difference that we can use to differentiate between walking and running. Because if we use just speed, for example, I'm sure some power walkers at the Olympics are faster than me when I'm running. So it's not necessarily walking, even though probably most of these people are actually running if we were to record them and slow them down. But flight time's the biggest difference. But there are other differences as well. Okay, as I touched on earlier, we've got differences as well in the upper body and the lower body. So we'll break it down. So in the upper body, our arms. So with our arms, they're moving a lot more. So there's a lot more range of motion, as well as we'll be bending our arms generally. And the reason why we need to bend our arms is because they're moving quicker. Okay, because we are increasing our speed, so our arms need to keep up with that. And there's a big difference between trying to move my arms quickly with bent elbows to be able to move it quickly with straight arms, because your arms have to move a longer distance when they're straight. So that's our arms, a big difference there. And then with our legs, we can see a lot of key differences in this picture. Okay, so from our hips, and I'll touch on this in the next slide. With our hips or pelvis, we're actually getting less movement in our pelvis compared to when we're walking. Okay, so it's important before we think about running, we want to make sure our pelvis and our trunk, so our torso, is really stable. Okay, because if your hips are moving around a lot when you're running, okay, that's going to make you really unstable, really ineffective, really inefficient for your running. So big difference there. So our arm movement, okay, and our pelvic movement is different. So pelvis decrease in motion, arms increase in motion. Our hip flexors, so the muscles that lift up our leg, you actually use them 9 times more when you're running compared to when you're walking. As you see here, probably from this last slide's a bit better, the amount of movement that you're getting in the upwards direction, okay, so how high does your leg lift up or your knee lift up in the air when you're running compared to when you're walking is significant. All right. And you're doing that for reps on reps on reps on reps as we're running really for a longer period, or you have more sort of steps that happen when you're running. So they're working really hard because apart from how high they have to move, they also have to move quicker when we're running. Similarly, with your calf muscles, they're working 3 times as much when we're running compared to when we're walking. So having really strong calf muscles is important. So being able to go up on your toes. That's why in our mobility, we want to make sure that we're able to walk in our toes, because that's going to give us the prerequisite strength to be able to run. And well, as somebody mentioned here who said this before, Rick said correctly, we also have a larger stride. Okay, so you have a bigger step length when you're running, as well as increased cadence. So that just means when I'm stepping, how quickly each step comes. Okay, so it's just quicker steps. So there's some of the big differences when we're running compared to when we're walking. So with all of that, it's important to recognize that we need to be training a bit differently, okay? And we need to be training these muscles a bit more specifically for running. But again, these items here might limit us from running, okay? So balance, spasticity, contracture, muscle weakness or paresis, and motor control. But we can address these things, okay? With balance, we want to work on both static and dynamic balance, okay? There might also be issues that you need to sort out depending if you've got issues in your inner ear, like vertigo. But generally, we want to work on balance by training balance, okay? So static balance is essentially balancing without moving. So that's standing and not moving, or standing on one leg, sitting up without moving. Whereas dynamic balance is balancing through movement. Okay, so if I'm bending down to pick up a pen off the ground, as I'm moving, I'm maintaining my balance. That's dynamic balance. When I'm walking, every single step, I'm rebalancing so I don't fall. That's also dynamic balance. Spasticity, as we talked about, can limit us. So general treatment for that is antispasmodic medication. Baclofen, Botox, they're all very appropriate treatments. What we find as well with spasticity, as people build up strength, that can also help reduce spasticity. When somebody has contracture, so their joint is stuck, you can maybe imagine how that can be really difficult to move to the next point. So if your knee is stuck in a bent position, for example, it's contracted there, then we won't even be able to get our legs straight to stand. So we want to make sure as a treatment, we might want to release that depending on the person, okay? And this is more that medical intervention for a lot of these, remember. There's something to remember when we are doing muscle releases though, because sometimes when somebody releases a muscle, okay, the muscle can get too loose and almost too floppy. All right. And as we'll talk about in a coming slide, we need stiff sort of joints, especially at our ankle, so we can stay bouncy. So if they release your Achilles tendon, for example, so the one at the back of your heel, which is actually this one here, if they release that and it's too loose, then you won't have the ability to bounce off that to get to running. Okay, so that will limit you. But also it can help depending on the situation. Muscle paresis, so we want to strengthen the muscles that are weak, or we brace them. Okay, someone's already mentioned they wear an AFO, so the ankle foot orthotic. That can be really appropriate to help there. And as time's developed, we've got so many improvements in sort of braces. So some even can be used when you're running, and they're light. They're really sort of flexible, similar to how our muscles and our tendons are. So we would just want to make sure we manage that. And then for our motor skill level, that's talking about our specific training. So if we haven't got the right motor skills, we want to be practicing that task. So we want to be addressing running specifically. And then finally, the missing link, which is no tendon time. What is a tendon? Okay, and you see here, I've got a picture of a spring next to the calf, because the tendons are basically like a spring in the context of running. Okay, so what are tendons compared to muscles? So muscles are muscle tissue. So when they contract, okay, or when you use the muscle, it will squeeze, it will get shorter, it will tighten, okay? And then that will actually pull on your tendon, which is a connective tissue. And that tendon then, because it's getting pulled on, it's attached to your bone and then moves your bone, which moves your joint, okay? So they work together, but they also are different types of tissue and require different ways to train them. Why they're so important during running is because they work as a spring, okay? So if you imagine when in this woman in the picture here, she's about to land on her foot, Okay, she's running, she's about to land on her left foot. As she lands with her foot, the Achilles tendon is going to stretch. So if you think about a spring, okay, think about a hard spring stretching, getting pulled out. It's storing then, the Achilles tendon is storing elastic energy, a type of energy, okay? And then when you push off that foot, when she's ready to take that next step straight away, she's going to release that energy in the tendon, like when you let go of a spring, and then all that energy comes through, boom, to give you that power to push off. Okay. So when you're running, it basically assists the muscles, okay, to help make movement a bit smoother and more effective. Without that bounciness that you'll get, the springiness in the tendons, what you'll actually end up doing is you're just going to be jumping from one foot to the next. Okay. Imagine like you're trying to jump from one rock to the next. Okay. You're not getting that smoothness and the basically the speed which is required to be running. So because they're different, we want to train them differently, as I mentioned. So muscles use resistance training, okay? We pick something up or we resist something. So for my bicep muscle, my muscle in my arm, I might lift up a weight, okay? And then I put it down. And I keep doing that to build up the strength, okay? Whereas for tendons, we want to be doing more plyometric training. Fancy word, what that means is plyometrics are fast, explosive exercises that train the body to use elastic energy to move powerfully. And there's a number of exercises we can do for this. As somebody mentioned earlier, trampolines are great. So bouncing and almost running on the trampoline can give you the assistance through the springs in the trampoline to assist that same tendon movement. But doing our bounding, doing our skipping, our hopping, okay, those jumping related movements, which we're trying to be quick on our feet, okay, and trying to be very bouncy, essentially, is what our plyometric training is. And depending on the person and their stage, there's a specific exercise that you'll do that's going to be the most appropriate for yourself. So just to recap, don't skip steps, okay? We want to make sure we have a foundation, okay, in our ability, in our skills, as well as in our strength and balance and all those other aspects before we move on to the next step. Sometimes you might be able to do multiple steps at the same time, but as long as they're appropriate. Next, do more good reps. Okay, as we said, most people probably can be doing more repetitions. Okay, they can probably make sure they're maintaining and increasing their intensity of the exercise. Okay, increasing the amount of sets and reps they're doing in one session and increasing their frequency of their sessions. Next, make sure you're training for running. Okay, so that's doing running specific exercises. And when you can start running, actually run. And this is also important for every other sort of mobility scale item. Okay, if you want to get better at sitting, okay, sit, do sitting specific exercises. Okay, if you want to get better at standing, actually stand. Jumping on the leg press at the gym will build you good leg strength, but it's not going to translate as directly as standing. Okay, and don't forget tendon time. For running, it's important that we are training our tendons, making sure we're getting very stiff, bouncy tendons, because if we don't, it's really going to limit how effectively you can run. And also it can increase the chance of injury because you're loading other joints, other structures. Just before we finish and get to more questions, so if you need help, as I said, I'm a mobile physio, so I go all around Sydney. So if you're in Sydney, you can contact me for that. Otherwise, I do telehealth to anybody in the world. So if you need help, you can email me, helpneostream@gmail.com, or DM me, so message me on any of my social medias. I'm on Instagram, Facebook, TikTok, YouTube. I got married earlier in the year, so I've been pretty terrible at uploading anything, but I'm looking at getting things rolling again. So hopefully I can get some valuable content out for you guys. And also let me know what you'd want to see from me. So the more ideas I can have about content, the better. But yeah, if you need anything, just message me on there. That's NeoStream Online on most of those platforms. So thank you.
I put all of David's contact information in the promotion where he signed up. I also will put it underneath the edited video in the description. clickable links, and of course you can't click a link to an email, but everything would be there for those of you here and those of you watching out in YouTube land. And David, if you have anything else you want to send me. I'm happy to put it there. But I've got your whole block that you already sent me. So
Beautiful. Thanks so much, mate. do you want me to, I can take off the presentation so I'm a bit bigger actually as we get into the question time.
great.
Yeah, there we go. Yeah, I have to take all questions. Let me just check the chat. Nothing coming up there. I'm just going to go from my screen left to right. So I've got Nita Rose.
Okay, I want to know if walking on your toes will help with the tendon, strengthen your tendon, or is that something separate? Okay. Another thing is when we're talking about task specific, I work out. I heard you saying working out and not doing anything task specific isn't helpful. So maybe that's my problem, because I feel that I do things around the house and that equals my task specific, but maybe I misunderstand it. Do I actually need to take like an empty cup and do that over and over like reps? Because like my water bottle, I'll take my hand and every time I take a sip of water, I think that's task specific. But is that not? I just want to get more clarity on that for running as well, where I have to actually do separate to training on my toes and bounding. How would I do task specific, and what is task specific?
Great questions. The first one, sorry, I just need to remember your first question. First was the walking on the toes. Okay. So yeah. Wait, what was the question about the walking on toes again? What about the walking on toes? Sorry.
To do the tendon exercises, because we mustn't work muscles. Walking on your toes, is that a tendon exercise?
Good question. So it works both. Okay, I think it's important to remember that. So walking on your toes will work both. So you're building up that calf muscle, okay, as well as the tendon, okay. But what you're building up, especially within the walking on toes, is your strength in that pointed toe position as well, okay. So building up your ability to be up on your toes without that collapsing on itself. Because with running, and some people like to run on their heels, and I even run with a heel strike when I'm going slower. But as we think about running in the most efficient way, generally we're running a little bit more on our forefoot, okay. So we need to have enough strength, stability, so that when we're landing on that, it just doesn't collapse onto our heel. So it's going to build up the strength there, but that also will build up strength in the calf muscles as well as the Achilles tendon. Whereas when you're doing more of your plyometric stuff, that's a little bit more tendon specific, where although you are still working your muscles, you've got a higher load on the tendons. Does that answer that question?
Yeah.
Lovely. Yeah. And then your second one there, with task-specific practice, it's all dependent on your goals, essentially. So whatever your goal is, okay, say your goal is to get better at picking up your bottle, okay? So then whenever you actually do pick up that bottle, you are doing a task-specific practice, but it depends in which way you're doing that. So if you're doing compensatory movements, so if you're chicken winging, which is something you'll get a lot early on with the elbow, that's developing a couple things. You're developing poor motor patterns. You're also developing slightly different muscles, okay? So the muscles that you probably want to be working that are really weak, it's not because you're compensating away from that, okay? So task specific is just depending on the task, okay? And we can do full and part practice with tasks. So with the picking up the cup one, you might just be working on the hand motion. So I might have a cup here, and then I might just be working on opening my hand, taking the cup away. Even that is a task practice, but I'm breaking that task down, okay? Whereas a full task, you might sit down and do it in the most perfect way that you can. So it just depends on the task. Does that answer that, Rose?
Yes, thank you very much. It does.
Lovely. I
real
love the giraffes in your background. I'm not sure if you can see. I've got elephants and giraffes and everything all around me, springbok all around me. So I love
real
it.
quick, real quick, and we'll come to Trent, Stephanie, and Daniel in that order because they raised their hand in that order. But while we're on this, they also had me, or I was suggested that I walk on my heels when they talked to me about walking on my toes. I found it real useful. You have to have pretty good balance before you start doing that. And then later in another therapist recommended walking backwards. So I wonder what you thought about heels and backwards while we're on the toes subject.
So for heels, love it. One, it works your balance pretty well. If you can walk on your heels, then you're pretty well balanced. Two, when we're walking, as a lot of people here might know, a problem that happens is when you get that foot drop or when you just drag that toe. So by walking on your heels, you're really working those muscles at the front of your shins, the tibialis anterior. So they develop that strength, the endurance as well. To carry over to your normal walking. Walking balance is really good. I find walking backwards almost forces people to walk a little bit better. It's hard to compensate walking backwards. So it's really good in that way. Plus, once again, balance again. And then walking backwards, I find translates really well to improving walking forwards. I use it a lot, especially even with my what's the word I'm looking for? My non-stroke people, because I do see here and there like injuries. So if somebody had an ACL injury in a repair, so like a knee reconstruction, I even get people to walk in their heels for some of that. So yeah, both really good. Just wasn't as, it's probably not as specific for running, but it is a bit of a, I wouldn't say it's a prerequisite, but can be great drills to be doing to develop your walking. Yeah.
Thanks. Go ahead, Trent.
Just to add on that, I mean, it also walking backward has been really good for my knees and reducing the pain in those as well. Just building that muscle up around there. One thing, David, that I didn't hear you mention, I realize this has to be done in a clinical environment or with a therapist, but is high intensity locomotor training. For me personally, that was a great, huge help, it feels like for me. Is that something that you're using as well on the proper uh, person?
Good question. I guess a lot of the stuff I was, because how I sort of, as me, a lot of the things I do is working with people at home. So a lot of these people can't get into a clinic and utilize a lot of the equipment, especially like treadmills and like harness training treadmills, which can be really important and really helpful. My my current perspective on high level locomotor training is it depending on how it's done. Like harness training is really good,
Mm,
okay, because then you can your center of mass, okay, and how it sort of moves is a bit more normal compared to if you're holding onto things on a treadmill. But strangely enough, I was doing a course last year, 2 years ago on running and developing there, but they didn't. The presenter wasn't a big fan on a lot of that stuff. But
mm,
I'm more of a I don't think it's as simple as that. It's quite nuanced. Everyone's a little bit different, okay?
right.
And if you're stagnating because of a certain reason, it can be quite helpful. I've used it in the past when I've worked in clinics, and I found it translates. But making sure you're getting enough what we call overground practice, I find is probably the most important thing. Yeah, no, but it is quite helpful. No, 100%.
Cool. Thank you.
One more thing then, Stephanie. While we're on that subject, what do you think about if you don't have a lot of spasticity, if you've worked
Mhm.
past that? And you mentioned earlier that a lot of times when you got strength, spasticity went away. I got full range of motion back and then I built it up. And as I built up strength throughout the full range of motion, I noticed that my spasticity decreased. And after that point, if you don't have velocity-based or big-time spasticity issues, what do you think about explosive exercises, things like frog hopping and butt kickers and things like that?
100% necessary. It's almost you need, and that's what like the plyometric exercises are. A lot of them are explosive. When you're doing those bounds that I really emphasized earlier, that's meant to be explosive because running is essentially explosive. Even when we're running slow, okay, it's still relatively explosive compared to what we normally do. So if you're not training explosively, you won't be able to probably get to running. Yeah, 100% necessary.
Go ahead, Stephanie.
Sorry, I'm all over the map. Just to revisit something, Ralph, you said about walking backwards. Is walking the stairs backwards, up backwards, also valuable?
Never done that before. Yeah, I don't know if I've ever done that myself personally. I'm trying to think about that. I wouldn't think so. Just thinking off the top of my head.
Okay.
One, because the motor pattern is very different to anything you'd ever do. Um, so it probably wouldn't translate that well. You'll develop really good sort of balance and coordination,
Yeah,
which isn't a downside. And then I actually need to go back to touch on something that Nita asked before about exercise at the gym and doing exercise for the sake of exercise. It's not useless, okay? It has its place. There are
right.
benefits, but it just depends on your goals at the time. But with walking backwards up the stairs, I would also just think the risk of that
This,
versus the reward probably doesn't weigh enough for me. Yeah.
okay. I don't do that without holding on. So, um,
Yeah.
so the steps within, moving forward through from walking to running,
Mhm.
is the assumption that I revisit those steps. So let's say I run, but I'm like Ralph, I'm not coordinated well, or it's not pretty, is what I tell my friends about my walking.
Yep.
Um, do I consistently go back and revisit bounding and toe? It's something that's a cumulative skill.
Great
Am
question.
I making sense? Yeah.
That makes perfect sense. Yeah, yeah. So once you get to those high level stages, a lot of that isn't something you'll do. Once you can do it, you're done with it. They
Mhm.
are skills that you'll be able to, and you probably should be doing continually. Um,
Gotcha.
like like professional runners, they do those things in their training constantly. Okay, so being able to make sure you are doing some of those previous skills. So even stairs, like being able to get downstairs quickly can be really, really important, a really good skill.
Mhm.
Usually I just do like the last 2 to 3 steps. But being able to bound, being able to practice hopping regularly can improve. So at your stage, what it sounds like, Stephanie, you just need to be working on some specific drills, so specific exercises that
Mhm.
work your specific deficit. So if it's the arm swing, you can't get the arm swing quick enough, or the coordination isn't there, then you might be doing things just for that without even worrying about the lower body. Okay, you
Gotcha.
might be working on just the legs. If you find you just can't get enough power to run, you just feel really heavy. You might be working on more bounding, or there's some skills you can even do before, like even on the trampoline, for example. But yeah, they are things you'll
Okay.
be doing
Yeah, I have
continuously,
an
ideally.
interesting situation where I don't have um, uh, motor restriction. However,
Mhm.
I do have, well, not severe, but pretty significant sensory. So I don't have the input going to my brain
Mhm.
that says where I am in space. And so I do feel like there is some compensation that's probably not helping me. And unless I'm carrying a bag, and maybe I need to do that all the time as part of the skill set, is unless I'm carrying something in my left hand, it's like for my brain doesn't even, there's a lack of recognition of a left side of me, although I
Mm.
can move fine.
And
So it's very weird, and it also makes me without the normal sensory input for even just that low level postural muscle thing happening. It seems like I'm longer now in the left leg. I'm more my joints are more mobile because I don't have whatever is holding me back on the right side.
mm.
So,
Yeah, so for that, a few recommendations that might be helpful for yourself and others. So sensory and proprioceptive deficits is really really impactful. And I can appreciate why you're having trouble with that.
Yeah.
So a few different ways you can approach it. Priming the sensory side of things. So getting different before you do your activity that you're trying to train, getting different textures, different firmness, and rubbing that around, vibration, all that good different sensory inputs can be helpful, as well as adding another sensory input while you're doing your activity. So doing something in front of a mirror, as you don't have that proprioceptive sort of feeling there. So if you have a mirror there, you at least have your eyes to know, oh, I do have an arm there. And there's lots of different ways you can approach it as well. Instead of having a weight, sometimes you'll get, if you've got a partner that can help you, holding two sticks on either side. So each person's holding something, and then you're practicing that movement with the arms with them. So the coordination is assisted by the partner that you're doing the activity with. But definitely, I think priming before is helpful. Adding an extra sensory sort of mode in there can be helpful as well as finding maybe some different exercises that might be a bit more specific and helpful for you based off your deficits. Yeah.
Great. Thank you.
Quickly, Stephanie.
Yes.
I'm not the physical therapist. David is. We'll see what I was going to tell you a couple things I did, and we'll see what he thinks about them. For working on proprioception, I took a frame for my feet. It's important, before we have our strokes, we didn't think about where we put our feet. We knew where our feet were.
Mm-hmm.
So that's an important skill to get back. So they'll put you on the parallel bars and a wooden block, and they'll have you touch the wooden block over and over. And what I did was I did that at home with a frame walker and a 4x4. And what I would do is what I call brain patterning. I would do 5 or 10 looking, and then I would close my eyes and try and repeat that movement that I had just sort of memorized in my brain. I did the same thing with my affected finger. I don't have one here, I took a basic sticky note and I put it in various places, and I would watch it and touch it, maybe similar to the mirror thing. The mirror thing is a good suggestion. So I'd touch it 4 or 5 times, and then I'd close my eyes, and I'm doing it right now, and I'm touching the same place. So that really helped me know where my body parts were in space. And one thing I did when I was walking, in order to get, you said you had coordination issues like me. My opposition still is a lot of problem when I run. But what I did was I called it like some modified power walk. My ex and I used to race walk. She actually beat David. We did a 5K, and she beat eight runners walking 13-minute miles. So I did a basic variation of I call it power walking. It's not race walking, because when you race walk, you have to have a foot on the ground at all times, and you do this little hip thing that I didn't do. But I did basically what's called like a power walk with real strong opposition. I started a little wider, like the monster John Wayne walk, and I brought it in. So those are the things I did, and we'll see what David has to say about them.
No, you're on the money there. I think that you did touch on something that I don't think I was clear about with the mirror exercise, where you do want to make sure that you are practicing without that visual item as well. Okay, so your body learns with the visual sort of source. So I'm touching this. This is where it is. Then taking that visual source away, and then trying to get your body to do it without those visual cues. No, 100%, Ralph. And then it's a lot of this is a bit about MacGyvering some things. I always use finding what you can do at home that will replicate something that you want to do outside of home or even in your home to create the most effective specific exercise for you, because those things will translate the most. But agree with everything you said there, Ralph. Great work.
Gotcha. Thank you, Dylan.
I'll be taking a sticky note and putting it on the mirror and seeing what happens, just because I fool around. I discovered a lot of this stuff myself, and I really looked into, I paid attention to what worked, and so I guess I kind of looked into like standard therapies. I actually sat on the edge of my bed and was trying to roll my fingers and couldn't do it. So I watched this hand, and then I did the same kind of patterning, bilateral patterning, and then 5 with this. Every time my affected hand fell apart, I would go back to both hands.
That's actually capitalizing on that. You have a very strong proprioceptive, sense.
Yes.
Even when I'm walking, or doing an exercise with my left leg, I'll find my left arm moving as a way to it just started happening without my impetus. So that's interesting that you say that. Yeah, all good ideas. Thank you.
Well, one more thing. Some people, I coach people, even though I'm not a PT, and they say I don't have any awareness of my hand, so I don't swing my hand. So I tell them to tie a ribbon around it or something that'll tickle them. Now, if you have no sensory perception whatsoever,
Right.
that doesn't work. But if you have a little bit, and you're just like, if you can feel things, but you're just not, you tend to, well, it sounds like you're still fighting through maybe left side neglect. I don't know. I'm not a neurologist either.
It feels like it's asleep all the time.
Yeah,
Yeah,
well,
like you get
I
pins and
have
needles and
I
yeah.
have paresthesia in my hand as well. But that's for maybe not for you, but for people out there in YouTube land. If you're ignoring your opposition, and I exaggerated my opposition in that power walk I did. You can tie a ribbon or anything, string, it'll tickle your hand. And even though mine's numb all the time, I still can feel a little bit.
Yeah. Okay.
Anyways, so we had a third person with their hand raised, but I don't see it now. Maybe we got to all 3 of the hands raised.
Yeah, we did 3. But any other questions from anyone else? Thankfully, I got my times wrong today, so I thought we started an hour later. So this works. I've got a bit of time.
Well, yeah, you got to go somewhere at 5, don't you?
I thought I did, but I got my times wrong. I did my what's it called? My translation from your Eastern time
Yeah,
to Australian. So I've got an extra hour now. So we're okay.
well, it's real difficult this time of year because, like in England, they aren't on daylight time. So we're normally 5 hours behind. Right now, for the next 2 weeks, we're 4 hours behind, and it'll be the same in the fall. Zoom does a pretty good job. But anyway, anybody got another question? I'm surprised Musong hasn't asked something, but that's just me. And you don't have to. You've always got a lot of good questions. Anybody?
Maybe I answered all of them in my thing. Who knows?
Typically, I do, but I think it's, this phase is just above and beyond right now. So I don't
Okay.
really have much questions, yeah. Because I got to
Where are
get
you
off
at
my
the
AFO.
moment?
I got to get off my AFO first, you know.
Uh, hello.
Yeah.
I'm so sorry, sir. Go ahead. I'm sorry. What you talk? You can go ahead and talk. I just had a
Yeah,
question.
go ahead, Daniel. Go for it. Sorry.
No, you're okay. I'm sorry for interrupting. My apologies. I have right now I am recovering from like 2 strokes that I had last year, but it made me like paralyzed like on my right side kinda, but right now I'm feeling some movement. Like I have a patch on my eye and stuff. But anyways, my question is like I have my left leg is the one that took a lot of the a damage, a loss. So I can walk now without a wheelchair, thank goodness. But I went to a medical health facility for about like 11 months. And also my arm, it's doing this like I'm Spider-Man or something. So I'm like really like right now I'm doing PT and OT. Um, and I've been doing that, but I've been only approved since like 2 weeks ago. So I've only been doing it for 2 weeks. So what should be my primary focus to get done? Because when I'm trying to walk and balance, it's hard to balance with my other hand, with my left hand, and having my left leg be like whatever, you know. Like, is there like should I focus on my leg or my hand? Can I ask that question? I know this is walking to running to what type of thing, but I was just curious about that. Like this conflicts with it sometimes because it like spazzes out. It's like really bad. Like right now, it's really doing that, but I'm not saying anything about it. Nope, nope. I'm gonna ignore it until it goes away.
Okay, no, you can ask
Anybody?
any question, really. Yeah, no, that's fine. And great question. I guess first, I just want to congratulate you on the progress you've made so far. It sounds like you're smashing it. You're on the right
Thank
track.
you.
Unfortunately, I can't really give you any specific advice without knowing
Okay.
your case specifically. I'd be sort of hesitant to say which way might be
Okay.
appropriate. But generally, it's based
Okay.
off your goals, really, whatever you want to achieve next,
Okay.
and working with
Okay.
your sort of PTOT team about what they might think is the most appropriate thing to work on next. But with your upper limb and your lower limb, there's no reason why you can't work on both of those things at the same time. Okay.
That's
If
true.
anything, I would say you should work on both of those things at the same time. As I mentioned earlier, with the how much sort of therapy can you do in a day or should you do in a day, there's really no
Yeah.
upper limit, especially if we're working on multiple areas. We're not worried that you're
Okay.
going to overuse the arm or overuse the leg because it's probably going to get too tired before we get to that point. So
Yeah.
yeah, work on both. Work on both.
Am I on good? And I'm sorry, I have another question, but this will be my last one. Am I in the good time? It's been a year since it happened, so am I like I went from the bed transfer stuff that we went through, right? But I used to use a lift and stuff to get out of bed. I used to use a wheelchair like every time I get out of bed, right? And with assistance, obviously. And then I graduated to actually walking without needing assistance, but I can't go long distances. So I have a walker now, but my thing is it's just like oh, it's a lot. But my thing is it's just like I'm starting to am I in a good place to keep it I'm healing fast? Like am I going on the right track here? Am I too late? It took a while for my physical therapy, my occupational therapy to be approved. Am I in a good space though? Still?
Yes, the answer is yes. You're in a great
Like right now
space.
I
You've
can
done.
stand up.
Mhm.
I'm sitting in a
What was
chair,
that?
but
Sorry,
I can
Daniel?
stand up. I'm sitting I'm sorry, somebody's calling me. I hung up on him. Okay, so I can stand up, right? But like you see, my hand is where's my hand? Oh, there. It's going outwards and stuff. Like,
Mhm.
it's just like multiple. If it's not one thing, it's another type of thing. But anyways, I
Yeah,
digress.
no, I
Just
get you,
thank you.
mate. No, you're definitely
Just
in a.
thank you for what you're doing, though. You're doing really like God's work right now. So thank you so much for your very honest to goodness great advice because I've been taking notes. Actually, been by taking notes, I mean by like I don't have a pen and paper, but I've been taking notes by texting my friend. All the stuff. They're like,
I
"What is
appreciate
all
it,
this?"
Daniel.
I'm like, "Yeah, I'm gonna write it down later." But I got that stuff, and the best part is my spastic hand is the one my writing hand. I'm a lefty, so
Mm.
great. Here we go. But it's
Okay.
okay. I got it documented, and thank you for this. Like, really, seriously, you're doing such a good job. Like, thank you. Okay. I digress. Bye. Bye. Bye.
I
Bye.
appreciate it,
Bye.
Daniel. Keep going, mate. You're doing well. Keep it up.
Thank you. I have to go now, so I just wanted to thank you and everyone
All good.
too. So be well, everybody. Recover well.
See you later,
Neuroplasticity
Daniel.
lasts a lifetime.
Thank you. You as well. Thank you so much.
Okay, anybody else? Or should we let David go?
Is that another one from you, Stephanie, or
Going
is that from
once, going
before?
twice. All right. Anybody
It
else?
was, I thought of it when Daniel was speaking. Way to go, Daniel. Don't mean to sound like your mom, but I'm really proud of you. And then I forgot what it was. So it was,
Well, if you have questions, like I said, like you can message
oh,
me Instagram, Facebook.
I remember now. I have a psychologist that lives near me, and she's friendly with me, a neighbor, and she had mentioned to me about when I was so anxious. I think we're so anxious as we move through these steps that you're talking about, progressive, is to get rid of our aids. Like I couldn't wait to get rid of my aids because for me it felt like I moved on to something. But she said, look, if you walk better with your walker, walk with your walker more, because doing it properly with proper form actually is feeding a pattern in your brain. And she said, I remember this from when I took my neuropsychology course in certification. And I wondered, is that something that you have subscribed to as well?
Yeah, because you do have like these feedback loops, we call it.
Right.
But when we're walking with our walker, I guess it all depends on the context of the situation.
Sure.
But we're walking with a walker, the only thing you really don't have is that upper body movement. Okay, but then the lower body, you should
Right.
be walking still with really good technique. The problem happens, which is correct with what your friend was saying, that if you take away the walker, you have to rely on your balance a lot more. So then that can make your gait pattern sort of worse, just basically.
Okay.
Sorry, I'm not sure if you guys can hear that baby. I'm just going to transfer over to earphones.
Yeah. All
Am I
right.
back now?
Yes.
Yeah.
Yeah. Oh, lovely. I'll just to quickly cap off that question. So yes, if your walking is significantly worse without an aid, then I would recommend probably walking with an aid, especially if it's in your day to day. The aid will help you just walk faster, safer, so you can just get things done. And then during your therapy time, you can work on walking without the aid till you get to a standard where you're happy enough and safe enough to be able to walk without.
I mean, I walk safely and I walk well. I think the walker just, so obviously there's a balance component to, I was under the basal ganglia as well. So in that balance area, I think it just allows me to remember that I do have a left side and I don't fear that.
Mm.
And so, I can walk and it's not too ugly without that. I do a wobble as I move side to side on the street and things like that. So I think the walker just sort of solves all of that for me. But I don't want to get lazy. So I hear what you're saying.
Yeah. Two birds with one stone. Keep attacking both. You're doing well.
Thank you.
I was going to say it sounds a little, even though you're not always aware of it, it sounds like walking aids often give you a little bit of relief from our old enemy, fear. And one more question for you, David, that came up when I was thinking about that. The other thing I think that aids often do is every time you change from one aid to another, because I've helped people transition from quad cane to a single point to no cane. And every time you do that, you go through a slightly different walking pattern. And if you, my experience is if you jump that process too much, that you can end up developing, you said something about bad, I'm going to call it bad habits. You said incorrect motion patterns or something like that. I found that breaking those, I found it's better to slow yourself down and work on form. I've always found form is more important than distance or speed. And I found that it was very difficult to get rid of a bad habit. For example, I didn't think I was kicking my foot forward enough on my affected side, so I started exaggerating it. Worked perfectly, except it took me 4 months to stop exaggerating it. And I've also found that people say, I want to walk faster. I tell them, form. Speed comes with form, and you're a lot safer if you don't train for speed. I did it a couple times. I'd find, especially early on, that my upper body I would lean forward to get the speed, and then when I tried to stop, I'm still leaning forward, and you get into that whole position where it's hard to lean back. And as anybody who has balance issues knows, pulling back from leaning forward is one of the more, I find it more difficult than left to right. It's kind of like walking down a ramp is much harder than walking up. And walking up, you can always go into puppy mode on all fours. Walking down like metal steps at like a medical facility, it's like, oh my God, if I fall, I'm going 3/4 of the way down, I'm hitting concrete and metal. So our old buddy enemy fear really grabs us. So anyway, I was wondering what you thought about, I'm sure that you agree about form. If you had any experience with like developing bad habits or getting rid of bad habits?
Yeah, well, almost everyone I've seen when we're starting walking has a bad habit. I don't know if I've ever seen anyone that doesn't start with at least a couple bad habits. And then it's all about working on those. A lot of the time, that's really hard to change, but you're just continually working on it. Sometimes I'll progress people from aids, even with some of those bad habits in it, because having the aid and not having the aid sometimes isn't going to affect that at all. You can still improve the bad habit even without the aid. So it's a little bit individualized in that sense. But definitely developing, if you haven't got a bad habit, then you develop it and you keep working on it. Because same thing as we talked about before with neuroplasticity and repetition. If you're getting lots and lots of repetition with your bad habits, then that's going to be ingrained in you. So it's going to take even longer to get those bad habits out than develop new good habits. So, I'm completely with you there.
Well, of course, when you're learning how to walk again, you're working on about 17 things at the same time. Heel strike, dorsiflexion, heel strike, push off the toe, don't let the knee lock, hip dip. It's a lot.
With a broken brain.
Right. It's insanity.
Anyway, so
yeah, and that's why I say a lot of the time I'll just get people to focus on one of those things at a time, because it can be really, really challenging and almost for many people impossible trying to fix 10 different problems at the same time. So just systematically, what's the biggest problem right now? Then working on that, then building up the rest. Yeah.
That's kind of what I did. Whatever was the worst, I would tend to focus on that a little bit, not trying to not. Of course, it's hard to have that much brain. I don't think we have as much brain processing power, particularly early on after a stroke. But I would tend to work
100%.
on like the one thing that was worse, not to the exclusion of the others. Maybe if I walk 4 times a day, like I did, 4 or 5 times a day, I'd think about the top 2 or 3. And when I'd walk one time, I'd work on that. And then I'd try to bring all that back and incorporate it into the, basic regular walk. Okay, I'm going to try and do them all as good as well as I can. It's tough.
Yeah, no, definitely.
Yes.
Yeah, 100%.
All right.
Great. Sarif, I think I might need to rush off now.
Yeah, I was going to say you've been very generous with your time.
Yeah, thanks, David. Thanks,
This
Ralph. Really appreciate it. Have a good day.
No.
Packed
Thank
full,
you so much.
packed full of great information. So thank you. And anybody out there in YouTube land that tuned in late, all David's contact information will be in the description under the edited video if you want to get in touch with him. And he does do telehealth therapy around the world, as he said during his presentation. So if you found this beneficial and you want to engage him, contact him. So thank you, David.
Thanks, Ralph. And if you guys would like to have me back, I'd love to come back and help out whatever way I can.
Would love to have you back, and I hope we can drive a few people towards you. That's
Appreciate that, Ralph.
the trade I make. You gave some valuable information to. We had as many as 32 people in here, which is pretty good.
Yeah.
Please. But the more important thing is this will live on YouTube forever. I've got one that's 2,500 views. Dr. Hetzler has one on neuroplasticity. It's about to hit 2,000. Dr. Winston on chironeurolysis has almost 1,000. So, there'll be hundreds more people that will benefit by watching on YouTube. So again, we'll let you go, and thank you.
Thank you. And thank you, everybody. Have a great rest of your day.
You do the same.